Good morning to everyone present here with us today. This is Shreyan from IJCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Anirban Sinha. Sir is MBBS, MD, DM Endocrinology, FAC Associate Professor at the Department of Endocrinology at Medical College, Kolkata. Sir is visiting consultant at Amri Hospital, Chairman Ethics Committee, Central Hospital, ACR Program Chair, MMSc Endocrinology at Texila American University. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is male infertility. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Yeah, sure. So thank you. Is my screen visible?
Yes, sir. Your screen is visible.
Yeah, let me see. So just a minute. Up. Hello.
Yes, sir.
So just let me make it full screen.
Sure, sir.
Okay, sure. Thank you very much. Is it visible now, right?
Yes, sir, it is.
But I cannot remove the hide the names of animations. But it's not removing. Hide
So,
floating meeting control. Right, now I got it. So today I'm going to talk on, thank you to the organizers first. Thank you for giving me the opportunity to share our knowledge on this, one of the celebrating happy day of Good Friday. That approach to male infertility is my today's topic. Without going to much of she has already introduced myself. So I'm going to talk about the following agendas like history, definitions, physiology, etiology of the disease, then epidemiology, step-by-step algorithmic approach, how to approach the patient, a brief of management, and the role of endocrinologist in that part of management, because management of infertility is a very big spectrum. It includes surgeon, it includes urologist, it includes many other ways, even the embryologist. All of them plays a role, but we will find out how does the endocrinologist role here, and lastly we'll take the take home points. Infertility has been known as a major medical and social problem since the dawn of human existence, because in many ancient history, ancient cultures, it is documented in the different ancient books and their documentations as a divine punishment in some cultures. In Egyptian society, for example, it is first considered as illness, and Hippocrates, who is the father of medicine, maybe, is created theories of number of causes of infertility, but unfortunately, most of them are not so scientifically valid. But he is the first person who tried to approach scientifically the infertility. Then the Renaissance period, there is significant scientific progress has grown into the understanding and the management of infertility. By definition, infertility is defined as unable to conceive after 12 months of regular, at least twice weekly unprotected intercourse. This is the WHO definition. Asia definition is the failure to achieve pregnancy despite having regular unprotected sexual intercourse for 2 years. What is the importance of talking about the definition is that it is not just infertility, is that after 2 months of marriage, some couples comes to us that I am not getting conceived. So this is not the way to look at it. You should try it for at least 12 months to at 2 years time with the regular intercourse. Sometimes due to lack of availability of the people in the busy schedule, this regular intercourse is also not happening. So these things should be kept in mind when we talk about infertility. And 8 to 12% couples are affected globally, and male factors is around 1/3, that is 20 to 30%. Contributory is another 1/3. So, and among the male factor infertility, 30 to 50% cases are idiopathic. Almost no cause are identified till now, though I will discuss some of the genetic factors and the mutations which can novel understanding of the pathogenesis. And among these idiopathic causes, many of them are actually because of those. 50% of the couples fails to achieve pregnancy in the first year, conceive in the very next year. So do not dishearten the couple that if you are infertile in the first 12 months, you will cannot achieve the fertility in the next 12 months even spontaneously. So that is the understanding of infertility. It is not fully understandable even if you are infertile with some people, but there are fertility issues with others. So there are many unknown factors plays as well. So coming to the different important factors like aging, lifestyle, physiopathology of the infertility, and the environmental factors of infertility. First, coming to the age, what happens to the with increasing age that more than 40, 50 years of age that actually impairs the cellular function in the whole of the body that includes sperm, vulnerability of the multiple disease that reduce the sperm motility and functions, modification of reproductive hormones, all the hormones throughout the body goes low with aging in most of the patients. So that is important factors. Andropause in the less onset hypogonadism is documented worldwide, but it is variable in the presentation age. Some people can even be further at the age of 60, but most of them becomes less fertile after the age of 50, 55 or something like that. Genomic instability is one of the important concern with increasing age, both in male and female factors, and that affects the fertility and functionality of the sperm as well. Lifestyle, most important factor and avoidable factor is the obesity. So if you are obese, you have a secondary cause of infertility, but if you correct your obesity itself can improve the fertility of the person. Alcohol and tobacco consumption, high energy intake, or that is the cause of obesity. High fat diets that again sometimes found in the different studies as the cause of infertility. Nutritionally poor food, recreational drug abuse, stress and anxiety all can cause infertility, and we have actually seen many patients of stress and anxiety precipitating the infertility. So these things should be kept in mind. Coming to the pathophysiology, as I said, the genetic susceptibility is there. Problems with the ejaculation or the sexual activity is another factor for infertility, though the sperms are functional. Patient ejaculation difficulty is there, or maybe the penetration difficulty, erectile dysfunction, all these things can cause the infertility. Secondarily, testicular injury or testicular disease. Many cases, a history of testicular trauma in the childhood as a potential presentation. Endocrine and other autoimmune disease can destroy the most of the cells in the body. It can affect the testes as well. Disorder of reduced fertility, poor sperm quality, quantity, and STDs and pathogens are important factors. Radiation exposure in the environment is a very important factor for many infertility, both in men and women. Tight fitting underwear, interestingly, they are found as a cause of infertility, which is a reversible cause. It should be kept in mind. Recurrent hot baths and saunas, many of the countries, this is actually a very common practice that can cause infertilities. Exposure to the endocrine disrupting chemicals, increasing in the toxins in the environment, and occupational exposure of the high heat exposure can also throughout the day during occupational factors can also cause infertility. I'm just discussing some scenarios of clinical infertility presenting to us, like an infertile couple approached to the abnormal semanalysis report and an absolutely healthy male partner, but otherwise normal, but only the semanalysis is abnormal. And secondly, a infertile man, known infertile with hyper or hypogonadotrophic hypogonadism, or the DST or disorder of sexual differentiation. This is a known disease, and this is the known spectrum of disease which is treatable of the endocrine perspective, and some patients only have abnormal semanalysis with absolutely apparently healthy male partner. There are different meta-analysis reported relationship between the mobile phone exposure as well. This is studies. This is actually a meta-analysis, especially from position close to the genitalia, reduce the sperm motility and viability. So putting the mobile phone in the pockets is one of the potential concern for infertility in the interesting studies. This is actually a meta-analysis which I'm talking about. So be careful and explain the patient about that. This is the spermatogenesis we all read about. That is the primordial germ cells to spermatogonia, primary spermatocyte, secondary spermatocyte. All these are important even now because every stage of this sperm maturation is important. because seminiferous tubule can be defective, Sertoli cells can be supporting cells can be defective. Then also that cause the, even if the spermatogenesis is normal, this can affect the fertility as well. Regarding the hypothalamo-pituitary axis, there is a feedback functions are there. GnRH stimulates the LH and FSH, which stimulates the testosterone, and also estradiol, which is converted by the aromatase, and this causes spermatogenesis. Sertoli and germ cells, which stimulate secretes the inhibin B, which feedbacks the FSH secretion, and Leydig cells, which produce the testosterone and estradiol, which actually inhibits the LH-FSH as well as GnRH neuron. So this is the synchronous secretion and balancing of the hormones in the pituitary as well as in the hypothalamo-pituitary axis. So any abnormality in this action can also end up in the infertility. Causes of infertility can be hypothalamo-hypophyseal. I was talking about that. That is the pituitary insufficiency, hyperprolactinemia, Kallmann syndrome, hemochromatosis, pituitary tumors, or any chronic disease cause the hypothalamic amenorrhea in the females. Similar presentation can be possible in the males. Testicular disorder in the lower end organ defect, like the infection in the testes, torsion of the testes, Klinefelter syndrome, testicular atrophy, Y chromosome microdeletion. Many cases nowadays found that's apparently normal, healthy person with a abnormal spermatogenesis because of the Y chromosome deletion. Even the systemic disorder like liver disease, kidney disease can also cause the testicular dysfunction. A seminal tract disorder, retrograde ejaculation, obstructive azoospermia, obstruction in the sperm that can be easily detected by the fructose level in the sperm analysis. Similarly, the immunological disorder, as I said, autoimmunity to the sperm can auto-destroy the sperm even after they are matured normally. That should be kept in mind when we decide on infertility. Psychosomatic disorders, as I said, that cause secondary infertility, depression, and anxiety states can also cause improper performance, and that cause secondary infertility in the patients. And many a times this is reality. And if you discuss with the patient, you can find that is an important cause. As an endocrinologist, we consider these from our perspective. That is hypogonadotropic hypogonadism, that includes isolated hypogonadotropic hypogonadism or other genetic hypothalamic disease, PIT1, PROP1 mutations, and there are 101 mutations which can affect the pituitary. That isolated LH-FSH deficiency, tumors like craniopharyngioma, other tumors, even the infiltrative disease like the vascular, even the inflammatory disease can also infiltrate the pituitary, stalk thickening, and cause infertility is secondarily possible. Pituitary infarction, be it a normal pituitary or in the tumor in the pituitary, can get autoinfarction or apoplexy. Traumatic brain injury, critical or chronic disease, even the drugs can cause, I will talk about the drugs later, can cause pituitary dysfunction. Among the testicular disorders, primary testicular failure can be Klein, anarchia, autoimmune testicular failure, or torsion of the testes, premature germ cell failure, primary germ cell failure, even with the Sertoli cells are normal. This is one of the important presentation. 5-alpha reactase resistance, deficiency, and androgen resistance is also in presentation of infertility. Among the 80 to 90% cases, infertility is caused by the primary or secondary hypogonadism, so that should be excluded first. Manifest most commonly by an isolated impairment of sperm production or function, may not be other features of hypogonadism, may not be so apparent. Just infertility presenting by the sperm defects are first. Primary disorder of testes, mostly idiopathic, accounts for 60 to 70% of the remaining cases. 15 to 20% of the cases caused by the genital tract obstruction. So lastly, that should be excluded by looking for the fructose level. 8 to 10-fold increase in the prevalence of the chromosomal abnormalities among the infertile men should be done. Coming to the obesity, which is a pandemic nowadays, and how it can affect it. Obese individuals are found to have reduced reproductive potential. Obese men with a higher percentage of sperm-induced genetic DNA fragmentation, abnormal morphology of the sperm, DNA breakage inside the sperm, epigenetic changes, and increased reactive oxygen species generation, and also can damage the sperm and in abnormal milieu of the sperm for survival. So rapidly destroys the sperm even in the vagina as well. So this is study shown the risk of azoospermic sperm is high in both underweight as well as overweight men compared to the normal weight counterparts. So you should be ideally healthy, normal weight, both malnutrition and the overweight or the overnutrition is detrimental for your sperm survival. So what are the nutritional factors have been found? That's unhealthy diets, high fat dietary contents, dietary fats, vegetables are less, and less exposure to the fibers, minerals. Even the pesticide in the vegetables can be a consideration. High intake of sugary beverages increase the infertility risk as well. So remember that. There are important endocrine disruptors like for testicular dysgenesis. Dose-dependent exposure like phthalates, bisphenols, pesticides are important factors. This actually as an estrogenic or anti-androgenic effects, their direct testicular toxicity, DNA damage of the cell lines, epigenetic changes, and increased oxidative stress or reactive oxygen species. So how it is approached? Assessment of men infertility includes medical history like physical examination, as I said, the testicular volume, palpation of vas deferens, testicular masses. Investigation includes morning fasting serum testosterone, LH, FSH, sex hormone binding globulin, estradiol. All these can abnormality affect the testosterone level. Falsely high SHBG can cause low free testosterone as well. Genetic factors like karyotype, Y chromosome microdeletion, if agiospermia or CFTR should be done if there is obstructive agiospermia or abnormal motility of the sperm. Hypothalamic pituitary disease should be this investigation actually give you the idea whether it is a hypothalamic pituitary disease or a testicular disruption or it is obstructive agiospermia. Then we take the infertility history, like the duration of the infertility, previous outcomes, partner's history, previous medical records, sexual function history like abnormal libido, because very low testosterone cause decreased libido. Erectile ejaculatory dysfunction is a different entity and that should be excluded as well. Types of lubricants, frequency and timing of coitus should be taken history of, and the past medical history like cryptorchidism, timing of puberty, anosmia present or not, Kalman syndrome for Kalman's, and testicular trauma, diabetic or any other chronic medical illness, infections, malignancy should be kept in mind. Post-surgical history like orchidopexy in the past, bladder neck surgery in the past, or even the vasectomy can affect your testis as well. Clinical assessment, toxin exposure like antipsychotics, antibiotic, pesticides, chemotherapy, radiotherapy can affect as well. So this history should be taken properly. Family history of infertility, family history of cystic fibrosis should be kept in mind. Physical examination, what we look for is a secondary sexual characters, whether it is a hypogonadism or is a hyper-hypo or hypo-hypo can be differentiated. Uh, Klinefelter, for example, have immature faces, tall stature, testicular volume, a size by the orchidometer should be done. Consistency of the testes, palpation of the vas deferens, penile length, meatal opening, any penile deformity, plaques, fibrosis, testicular mass or palpable testicular tissue, abnormality in the testes, undescended testes present or not, be it a present or in the past, should be taken care of. So what is the importance of testicular volume? So minimum 4 ml is important to start with the normal functionality, that is the pubertal onset. Otherwise, this function very low cell that actually have less germ cells, so functionality is less. And before that, most of the cells below 4 ml testis, most of the cells are Sertoli cells. So functionality increases when the testicular volume is more than 4 cc. Seminalisis, very first test used most commonly to rule out male factor infertility, and that should be done first. Street criteria to assess the morphology of the sperm and the standardized set should be there. WHO criteria are mostly used throughout the world. So this is the WHO criteria. So it does not show the very high concentration is required. Only 15 million sperm per ml, and progressive motility only 32%, and total motility more than 42%, and vitality more than 58% is important. For morphology, more than 5% normal forms are important. And how the terminologies are coined, like oligospermia is a form concentration less than 15 millimole, asthenospermia is a motility less than 32%, teratozoospermia is a normal morphology is less than 4%, oligoasthenospermia is all the above three parameters are there, then teratospermia. Agiospermia is no sperm detected, normospermia is normal sperm parameters. So this is the term we should remember when we analyze the spermatogenesis. An advanced semi-analysis can be done, if possible, in the certain centers like the sperm DNA fragmentation, comet assay, tunnel test. These are very important, and we can look for the reactive oxygen species like the chemiluminescence assay, or the mitochondrial functions or mitochondrial membrane potential can be looked for, acrosome reactions, and sperm Jonas pellucida binding. All these things can be looked for, and the sperm structural abnormality can also be looked for, like the sperm head defect, sperm meat piece defect, and the sperm tail defects can also be detected. Even if the normal sperm count is there, this can affect your fertility. Approximately 30 to 40% of the men with idiopathic infertility shows the increased concentration of the free reactive oxygen species, which I'm saying in the advanced sperm concentration or candidate marker for male infertility. So ideally, the normal sperm count, even if the infertility is there, reactive oxygen species should be done at least. So this is the advanced semen analysis, how it is done. Light microscopy can be done for DNA fragmentation. Fluorescence in situ hybridization testing can be done. Postcoital test for Y chromosome microdeletion, sperm penetration assay, and the hemizona assay. These things can be done as a functionality of the sperms as well. As I said, the basic hormonal evaluation remains the testosterone, LH, FSH, SHBG, and inhibin B, which is the feedback inhibition factors. Hypo and hypergonadotropic hypogonadism is excluded. So this is how we look for it. Low testosterone, high FSH, high LH is affecting the spermatogenesis. The karyotype is needed in this situation. Then the low testosterone, low FSH, low LH is a secondary hypogonadism. Look for the MRI or the pituitary defect is a factor. And then high testosterone, normal FSH is the partial androgen resistance. Normal testosterone, high FSH, normal LH is the primary hypogonadism. Seminiferous tubular damage is the ideal concentration because that LH is normal, but only FSH is elevated because of absence of feedback inhibition. And normal patients with the, even if the infertility is there, but it can be normal testosterone, normal LH, FSH. Second stage is the scrotal USG. It's a non-invasive, less costly procedure able to identify the mass or varicocele. A transrectal ultrasound, we can look for the obstructive pathology, be it the prostate or in the other areas of obstruction. In difficult situation, MRI can be considered. Genetics are nowadays coming up in a big way for karyotype. After the karyotype in the infertility cases, presence of certain genomic abnormality, which repeated ICSI, failure, recurrent miscarriage possible. Like when it should be done, when the sperm count is less than 10 million and family history of recurrent abortion, malformations are there. Y chromosome microdeletion is most commonly done in the patients with azoospermia or oligospermia. CFTR is the cause for infertility. What are the tests done? To look for the DNA fragmentation is the Tunnel-10, CAMA3, or SCASA test or Halo test, Comet test should be done. If they look for the mitochondrial DNA damage, we look for the reactive oxygen species, chemiluminescence, or the tunnel test for the DNA integrity. Telomere attrition can be measured by the telomere measurement length, and Y chromosome microdeletion either by the karyotype assessment, multiplex PCR, microarray assessment, NGS sequencing can be done to look for the Y chromosome microdeletion. Epigenetic abnormalities are 100 of ones, and some of them are not clearly identified till now. That only can be done by the array-based DNA methylation profiling or NGS sequencing. So this is a very advanced test, not frequently available in the periphery, but this can be done in the advanced setting, with increasing advancement in these scenarios of genetic possibilities. For example, Tunnel test is a very robust and highly reliable test for single and double strand DNA breakage. And when the spermatozoa from the neat, washed, and cryopreserved seminal sample, and Tunnel test is very easy, it should be done to look for the reactive oxygen species effect and the DNA fragmentations. And these are the epigenetic assays. I'm not going in details. The very important test nowadays required is the Y chromosome microdeletion. There are three zones, AZF-A, AZF-B, and AZF-C. Depending on the abnormality that can present with azoospermia to azo-oligospermia. Histology can be detected by the Sertoli cell or Sertoli or germ cell arrest. And AZFA has a virtually nil sperm count, but AZFB or AZFC can up to 50 to 70% sperm count, but Y chromosome defect end up in multiple defects. This is the epigenetic factor defects. There are certain upregulations and downregulation causing the, as I was talking before, that idiopathic men infertility are nowadays found about most of the cases are transcription and epigenetic factor defects, and increasingly they are found both in azoospermia or as well as the epigenetic defects in the other situation. So this is how we approach as the evaluation of the couple. I'm not talking about women. Men, we look for the history, physical examination, laboratory evaluation. Then we look for the low testosterone, high LH, FSH is the primary testicular failure. Normal testosterone, high FSH is the germinal compartment failure. This is the Y chromosome microdeletion. Look for should be that. And low testosterone, low LH, FSH is the hypogonadotropic hypogonadism should be looked for. And the testicular defect as a central pituitary cause should be looked for. And the normal testosterone, normal LHFSs, we should go for seminal analysis. Agiospermia, we look for the postcoital ejaculatory urine and the seminal fructose level to look for the obstruction. Then we look for the Y chromosome microdeletion and other epigenetic tests, as I was discussed before, to look for the defects here. And oligospermia, again, we look for anti-sperm antibody and other specialized genetic defects in this situation. Coming to the brief of management, like the prognosis should be assessed, whether it is a reversible, irreversible. Psychological counseling is important because, as I said, even after 12 months of infertility, couple can go pregnant. Second part, fertility for the female factor should be evaluated along with, because sometimes people think that let's correct the male partner first, then female, but that way we spend more time with the late marriage nowadays. After the 37, 38, most of the people become a defect in the sperm as well as in the ovum. So try to treat them together and find out the defects. Coital timing calendar should be adjusted. Lifestyle changes, quitting tobacco, alcohol, moderate weight, regular physical exercise. I'm not going in details of how it affects it. Pharmacological intervention, as I says, aromatase blocker, pituitary affection, as well as stimulation of the Leydig cells, stimulation of the Sertoli cells can be done with the multiple hormones. For example, hypogonadotropic hypogonadism with the low sperm count, go for SCG 2000 units 3 times a week, and total testosterone after every 1 to 2 months. And if it is more 400 to 800, no, then adjust the SCG dose to increase by up to 5000 units. If it is yes, continue the same dose and every 1 to 3 months. And if the sperm concentration is more than 5 to 10 million, when the testosterone is normal for 6 months, if it is yes, then continue the same dose and try for the fertility. If it is not, then start the HMG 75 units 3 times a week, or increasing the dose later on if up to 150 units 3 times a week, and wait for at least 12 to 24 months with the whole treatment, then consider failure and consideration of the ART, artificial reproduction techniques. Why LH is given? Because HCG induces the increase in the intertesticular concentration of the testosterone, which is essential for spermatogenesis, and HCG is less expensive than FSH as well. So GnRH therapy has been tried, but it is difficult to use because it requires a pump like insulin pumps. It is a favorable response is found in the prior sexual maturation, no cryptorchidism, and the serum inhibin B is more than 60. Clomiphene is a weak estrogen receptor. It is mostly used off-label. It's a variable prospect, and we commonly do not use it. Concurrent testosterone HCG therapy has been tried, and it has been a varied success. So there are other non-enzymatic antioxidants has been tried to improve the sperm motility and sperm concentration, like the coenzyme Q, carnitines, lycopenes, melatonins, and others. And then we come with the artificial reproduction technique like sperm extraction under control in hormonal situation, and ICSI in the reported cases. This is actually a teamwork, and role of the endocrinologist is actually synchronize the situation, like treating the hypogonadism, correct the infertility prospect, and liaison between the other team member, like finding out the genetic defects with the geneticist. Couple counseling is important factor as well. So this is a very complex picture of the infertility of the male. We can see here, endocrinologist lies here as a hormone therapy and synchronizing with the other parts of the treatment, be it obstruction in the surgery, be it techniques like genomics, proteomics for the patient. Stem cell therapy can also be considered. Even the gut microbiome correction is important aspect. I'm not talking about this in the brief perspective, but all these things can affect your fertility, but correct your healthy life and healthy diet is the only way. So male infertility is a variable entity as a psychological, socioeconomic concern as well. So that should be considered when we treat the patient. First step of evaluation is the seminal analysis, and WHO guideline should be followed. Psychological support plays a big role for the management, and gonadotropin replacement in the certain situation may improve the fertility. Thank you very much. Over to the organizer.
Thank you so much, sir, for your wonderful presentation. So we do have some question if you'd like to take that up.
Yeah.
So, sir, the first question is, how do hormonal imbalance such as hypogonadism impact male fertility, and what are the recommended approaches for the management?
So hypogonadism, as I've said in the presentation, there are definite treatment. I did mention in the slides. If you have correctly followed it, I will show you the slide again. So this is how the approach is done. So this is the low testosterone. Let me correct it again. So this is the low testosterone, high LHFSH. This is the primary testicular failure. This is the hypogonadotropic hypogonadism. In this situation, as I mentioned, then you treat with the patients first with the ECG. Here, then with the ECG with increasing dose. If the looking for the normal testosterone level, at least every 3 to 4 months, you test the patient, and then if it is not adequately corrected, increase the dose, then starts the HMG 75 units 3 times a week, then increasing the dose to up to 150 microgram units 3 times a week. At least try it for 12 to 24 months, then consider it as failure. That is the way we treat the infertility in endocrine perspective.
Thank you, sir. The next question is, can you discuss the potential role of adjunctive therapies such as antioxidants or hormonal supplement in improving male fertility outcome, particularly in case of endocrine dysfunction?
See, hormonal supplements are nothing like oral supplements. As I've said, injectables are the only option for the hormones. And definitely clomiphene has been tried as the off-label indication, but it is not a variable success. And this is the non-enzymatic antioxidants people have tried with a variable success. This is the data available in the gist of different studies. And some of them are helpful, so you can try this out, like the coenzyme Q10, like creatinines, lycopenes, melatonins, alpha lipoic acid, omega-3 fatty acid, but these are not a guaranteed success. So these improve the sperm volume, concentration, motility in the variable studies, but not all the studies confirm that this can help you out. So you can try this in the simple way.
So there's one last question. In case of idiopathic male fertility, which endocrine evolution should be performed, and how can abnormalities be addressed to improve fertility outcome?
As I said, you should go with the proper techniques. As first is the semen analysis with the hormone analysis. I did mention the approach. Where, yeah, this is the approach. We go for the history physical examination, then look for the laboratory testing, and then go for the, if the laboratory testing are normal, we go for the semen analysis. And if the semen analysis are abnormal, like the azoospermia, first we exclude the obstruction, and we look for the common factors like Y chromosome microdeletion easily available. Otherwise, we look for the multiple epigenetic changes we discussed, like this is the epigenetic, this is the other tunnel test, CAM3 testing. These are all available in the advanced labs. This is to look for the DNA fragmentation, DNA damage, epigenetic changes, Y chromosome microdeletion, telomere attrition. All these things can be done according to the situation of the patient. So first, exclude the hormonal disturbance, then a normal semen analysis, as I mentioned before. So advanced semen analysis includes the head defect, mid-piece defect, tail defects, or the reactive oxygen species level, acromia reaction, sperm DNA fragmentation, all can be tested. This is the normal target for the defects in the head piece defect, tail defects, cytoplasmic defects, vacuoles. And this is the WHO criteria for spermatogenesis and normal sperm parameters. Like this is very important to exclude that there is abnormality there or not. Morphology more than 4%, motility more than 40%, and sperm count more than 15 million spermatozoa is good enough for normal fertility. Just remember that. So after that, variable approach depending on the situation of the patient. Okay.
Thank you, sir. Thank you so much for answering all our questions, sir. So before concluding today's session, sir, any last remark from you?
So as I said, it has a multiple approach. Take home message is the last statement. Maybe it has to be approached properly, and both of the people in the couple should be treated together. Psychological factors should be looked for. Many a time we realize that it is a secondary cause of infertility because of the mating difficulty, because of the pain during mating, or psychological phobia, performance fear, many things affects which is beyond the endocrine perspective or maybe the scientific perspective in the true sense. Even if everything is normal, just a fear, phobia, lack of time, psychological hindrance, uh, all these things can happen, and we have seen it in reality. So exclude those before going for a proper evaluation of the endocrine and the spermatogenetic factors. Psychological support plays a big role. Just assurance can improve the fertility. I have seen many patients as well. And if you require accordingly, after your reports, treat the patient with endocrine perspective or artificial reproduction according to the patient situation. Thank you very much.
Thank you so much, sir, for joining us today. And with your permission, I would like to conclude today's session. Thank you.